Okay, we're back again to talk about some of the childhood diseases, and there are many, but there's three main ones that we really want to focus on. The first is congenital hip dislocation, which is really a spontaneous dislocation that happens during, often before or during or even after childbirth. So the cause of this is an underdeveloped femoral head that dislocates. So when it dislocates, it moves upwards and outwards, or posterior and superiorly, out of the acetabulum. So we need to familiarize ourselves with three actual separate entities that are involved in congenital hip dislocation. The hip dislocation itself is when the femoral head is completely displaced. So the head is actually out of the acetabulum. And versus a dislocatable hip, that means that the head is in the acetabulum, but if you were to perform some sort of provocative maneuver, it could actually move out of the acetabulum. So a hip dislocation is that it is out. A dislocatable hip is one that can still dislocate, but at rest it's resting in. And a subluxated hip, which is when the femoral head is sort of halfway out but not completely out. I always think of climbing over a fence and you get your pants caught on the top of the fence. So you can't go one way or the other. So it's subluxed, it's caught. It can't go into the acetabulum, back in, and it can't go out of the acetabulum. So we call that a subluxated hip. If we were to take the term dysplasia, really all it means is abnormal development of the hip. So we have to ask ourselves, who is it that's going to have congenital hip dislocation? As I said to you previously, the incidence of CDH is going down considerably because of the neonatal screening for this disease. But even at this point, it's still 5 to 8 times more common in females, and it can be bilateral in roughly a third of the cases. For whatever reason, the left hip seems to be more commonly and more worse affected, to the tune of 3 times as more commonly involved as the right hip. It's also more common in infants who come into the world feet first, so a breech delivery. And again, that can be related to the mode of delivery by the pull through the lower extremity. There is a higher familial predisposition in families. What is interesting is this is a congenital anomaly, which means that it started in utero, and so at a time when other anomalies are happening. And so one of the often you see is children who have congenital dislocated hip often also have torticollis, which is a sternocleidomastoid problem. So the head is tilted one way and the chin is rotated the other, and that this happens in roughly 20% of cases. And again, that's because they're both congenital anomalies. Their failure to develop or form in intrautero, and it tends to happen at roughly the same time. So if a child was born with torticollis, they automatically are looking to the hip, and vice versa. If a child is born with CDH, they will definitely be looking for other congenital anomalies. What is important is when the treatment is started after the age of 6, the prognosis is not so great. But ideally, when it can be started within the first couple of weeks after birth, that's when there's less likelihood of developing osteoarthritic changes down the road, and the prognosis is much, much more favorable. So when you look at this x-ray, what you see is the acetabulum on the right there is very, very shallow. It's more like a saucer instead of a cup. And you see that the roof of the acetabulum is very vertical. And so that allows the femoral head to slide out posteriorly and move superiorly as well. I'm just going to go back to this first slide. What you're seeing in this slide is actually what is called Ortolani's test. And it is a test that is being done now to test neonates. And really what's happening here is they are looking for congenital hip dislocation. So what they will do is put thumbs medially on the front of the hip, and the fingers are on the greater trochanterus. And what they do is they flex the infant's hips to 90 degrees and then gently try and abduct. And normally when you do that with an infant, as long as the infant is fairly relaxed and not screaming and crying and muscles are in spasm, but normally there's a nice smooth transition then into almost 90 degrees of abduction in that flex abduct position. But in CDH, the movement's usually blocked, but by applying pressure to the thumbs, or applied to the greater trochanter, that actually reduces, so it clunks, and then the dislocation reduces. So what blocks the hips moving into that abduction is the fact that the hip is dislocated. But by applying pressure from behind to the greater trochanter, the examiner is actually reducing the dislocation. So sometimes it will clunk, and then the hips will abduct fully then from that position because the head has now moved back into the acetabulum. If the movement gets blocked, however, at that halfway point or anywhere in that range trying to go into abduction, that's considered an irreducible dislocation, and that would, the chances are, require surgery. But again, this all depends. The infant has to be fairly relaxed to do this. Otherwise, the blockage or the apparent blockage is simply the child contracting muscles if it's crying or screaming. So what do we do if a child has a positive Ortolani's test, or what happens if they have CDH? Well, normally, if it's possible, what they'll try to do is to double or triple diaper. And that is good for the sense of abduction, but what it doesn't do is maintain the hip flexion. So if they're really concerned, because the whole idea is that the head of the femur and the acetabulum will develop normally if you can reposition the head in the acetabulum and maintain it there. So if that's not being done by double or triple diapers, then they will use what's called a Pavlik harness, and that's used for dislocatable but reducible hips. And again, it has the advantage of not only maintaining the abduction, but also maintaining the hip inflection. And again, that's used in infants usually from birth to 6 months, and it's worn 24 hours a day, usually for 2 or 3 weeks. And then after that, 23 hours a day for another 3 weeks, and then 12 hours a day for another 6 months. So this is worn for a significant period of time. The advantage then is, again, it's preventing the hip extension adduction, which allows the hip to dislocate in that posterior superior direction. So if you think back in history, and you think of Native North American, the way that they carried their children was in a papoose, which was with the hips extended and internally rotated. So looking back in history, there was actually a significantly high incidence of CHD in the Native North American population because of the position of the hip being placed after birth. What is important to know is that with the Pavlik harness, or in the right diagram, there's actually a brace that can be worn. It's a little bit firmer. For older children, there's an 85 to 90% success rate in correcting that dislocation. This is a hip spica cast, which also, the problems with the cast, unfortunately, however, is that it does result in difficulties with looking after personal hygiene for the infant. But certainly they leave the window there for bowel bladder functions. Late-calf birth disease is probably most common in males, so it's 5 or 6 times more common in males than females, with the peak age around 6, but certainly between the ages of 2 to 12. And so these children are often very delayed in their skeletal maturity. And there's a very high correlation between these children developing this disorder and low birth weight. So what is it? It is an avascular necrosis of the epiphysis of the femoral head. So the good news is generally it is self-limiting, and often it will heal without any treatment within 1 to 3 years. The good part about this, so the head loses its blood supply, but it can regenerate in young children, especially below the age of 5. So it's capable of self-regenerating. So what happens? So there is a high familial incidence. It is bilateral in roughly 15% of cases. But what's most important here, so it's one of the most common causes of a painful limp in childhood. So from that standpoint, on this X-ray you can see the flattening of the femoral head, which is called coxa plana, and you see the enlargement of the femoral head, which is coxa magna. And you can see that that head doesn't fit well in that acetabulum. So that's certainly a problem. It's caused, not really sure what causes it. There's a lot of could be trauma, could be infection. Certainly 50% of children who develop this seem to have had some previous trauma, but a lot of cases there's just no known cause for it. So what is the treatment? Continual traction is rarely used now because it requires traction in bed for 1 to 4 weeks, which is really, really hard on young toddlers and young children. Certainly they can use, this is an abduction brace, which is again maintaining the abducted position, so it keeps, and lateral rotation, it keeps the hip positioned in the acetabulum. And that again, and I'm going to show you a later picture which has the Petri cast. That can also be used here. And I'll show you a picture of that and comment on it. So again, the whole idea is to allow for normal position of the head in the acetabulum to allow the blood to be restored. Surgically, they try not to do surgery, but if it's necessary, they can do an osteotomy, which is a removal of a piece of bone, again, the purpose being to maintain the head in the acetabulum. Subcapital femoral epiphysis is now considered a growing problem. Again, there is no known cause, but there certainly has been an association of this problem with children who are obese. So it is the most common hip disorder occurring during adolescence. So it is slippage of the femoral head off the neck, so it's a slippage at the growth plate. And that slippage will continue either until the adolescent reaches skeletal maturity, so it will fuse there, or until there's surgical intervention. So the slippage actually happens during growth spurt, which hence the adolescent period. So certainly males are more common by a ratio of 3 to 2, and certainly males most commonly at the age of 12 to 16 because they mature skeletally a little later. Females are much younger. And when it is bilateral, 15% of cases it is bilateral, then the incidence is actually higher in females. So normally when it's unilateral, males have a higher incidence. Again, what's really important here is 75% of these children are overweight and have delayed skeletal and sexual maturity. So that is why it is a concern. It's a disease of the future and one that you're going to see a lot of coming up. And we'll see the results of it in 20 years when these children develop osteoarthritic change. What is important with these children is that 20% of these children will have no symptoms, and that there is no correlation between the amount of slip and the amount of symptoms. So these children could very well come into your clinic. They may or may not be limping. They may or may not be complaining of pain. But this is the Petri cast. So this is a short leg cast. It's a spica cast. The hips are held in abduction, lateral rotation. These children are actually amazingly mobile in this cast, but they're quite lethal because the cast is fiberglass. So when they walk by swinging their hips, and they tend to contact, pets, shins of other people around them in their ambulation. So it's quite eventful for the whole family when these children are maneuvering around. Osteoarthritis is again, we have to look at the cause. There is primary osteoarthritis and there are secondary. So primary, we're not really sure what causes it. Secondary then is due to perhaps like Cuthbert's disease, split capital femoral epiphysis, trauma, fractures, dislocation, congenital hip problems. So certainly what we do know about osteoarthritis of the hip is that it's more common in females by a ratio of 3 to 2. So primary osteoarthritis, no known cause. There may be a familial history, but it results in pathological aging in the articular areas, those that are undergoing weight bearing. So it's often referred to as a wear and tear. So the areas where there's absorption and squeezing of the synovial fluid are the areas that are most affected. Where secondary arthritis, again, it depends on what caused the damage, and certainly there's a higher incidence of osteoarthritis, secondary osteoarthritis in the obese. So on x-rays, we see the classical findings, the white sclerotic line, which is the change in the bone. We see the narrowing of the joint space, and we see osteophytes on the edges of the acetabulum. On the x-ray, it's labeled as bone spurs. Those are called osteophytes. So certainly, total hip joint replacements are commonly used both for osteoarthritis and rheumatoid arthritis. And again, we need to understand how they work. And I know Anne is going to talk to you more about this in your acute care setting. So I'm not going to talk about the post-op protocol. I'm just going to talk about what happens. So it has a stem and it has an acetabular component. So these can be cemented and they can be done uncemented. So you see the stem, the femoral head, and the acetabular component. And they have, generally speaking, a very rough surface that allows the bone, the surrounding bone, to grow into the stem and the acetabular component. So cemented, again, is done usually if there's very poor bone stock and more in the elderly. So what they do is they clear out or clean out the bone, so they burr down and take out the bone. They make a paste, they put the stem in, and then they pack the bone cement, the glue that they've made from the crushed bone that they removed to make this channel for the stem, and they pack it in around the bone. Uncemented is usually done in the younger who have better bone stock. So the canal for the stem is actually much smaller, and so the stem is actually hammered in, so it's very, very tight, very, very snug. But there is no, and the bone will grow into it because the coating of the uncemented is very porous, and the bone will grow. But they tend to be, surgeons have these individuals less weight bearing because there's no cement. Most commonly, a lateral approach is done, and that's good from the sake of surgical complications and for the rate of dislocation. But the problem with the lateral approach is the muscle that is cut and injured to get to the hip is gluteus medius. And gluteus medius is probably one of the major muscle weakness that these patients have pre-op. So when you cut through the muscle and you had surgical pain and scarring and weakness following, this is a really hard muscle for physios to get retrained afterwards. So that's a particular complication for us as clinicians. So what happens surgically then is they will remove the femoral head, they remove the ligamentum teres, so that means loss of proprioception. They ream or dig out the acetabulum, and then they put in the acetabular component. Then they ream out the femoral canal, so they dig it out, so they drill out that canal. So if they're going to use cemented, it has to be wider. And if it's uncemented, they'll have a narrow canal. The hardware is actually measured out long before the surgery for the patient. Then they literally drive the femoral stem in before they put on the hardware for the head. And then, again, they'll make sure that the hip moves well while the patient's still under anesthetic. They may use sutures, they may use staples to close. So that diagram on the right there shows you a fairly extensive incision site. All right, so now I'd like to talk a little bit about anterior hip and groin pain. I think you can appreciate in both these two instances that it's quite a significant injury. We can all look at those pictures, whether they were males or females, and go, oh, that's got to hurt. So what are the causes of anterior hip and groin pain? Well, certainly osteoarthritis of the hip is one of the most common, and it affects 20% of the population over the age of 55, and that climbs to 85% of the population over the age of 70 to 80%. So it is an incredibly common problem as aging baby boomers, so it's one that you're going to see more and more and more of. So again, is the cause, is it primary where we don't know what causes it, we get pathological aging, or is it secondary, caused by some sort of trauma or childhood disease? The other thing that we have to consider that causes anterior hip pain is the iliopectineal bursitis. Now, this has a very high association with OA of the hip, and also a tight iliopsoas muscle seems to be contributing to this. So this is an overuse problem as well, so it can occur in runners. It is a friction rub, so it's a rubbing of the tendon over the anterior ridge. So the pain is in the groin and can radiate into the anterior thigh. So they have problems with hip flexion and abduction and internal rotation, and pain with extension. So again, part of the treatment for this is, yes, to settle down the inflammation, to settle down any swelling, but the more importantly is to reduce the overuse and to treat the OA, the underlying OA, or to treat the tight iliopsoas muscle if that is what is causing it to rub and create a reaction in the bursa, the synovial reaction. When we look at adductor muscles, these are very, very common injuries. We talk about muscle strain, which we said was mid-substance, and also adductor tendinopathy, which tends to be more where the muscle attaches to the tendon. What's interesting to know about adductor muscles is we tend to think of them as occurring with, doing the splits or goalies stretching. But often adductor strains and adductor muscle injuries happen late in the game, particularly strains. They happen late in the game when there's fatigue, and they often happen when the individual is switching, so a slap shot or changing directions, when they're switching from eccentric payout of the muscle, so abduction, external rotation, extension, to making the muscle contract concentrically, so making it flex, adduct, and internally rotate. So there seems to be a problem. So these injuries happen not by terminal stretch, but they're happening more in a transition from working eccentrically, as the hip is abducting, externally rotating and extending, to contracting in a quick movement, a quick activity, particularly in soccer and hockey, to flexion, adduction, internal rotation. So they mimic each other, except for the area of pain with the strains being more mid-substance. They both follow the theory of selective tissue tension testing, and pretty much the treatment is the same for these. So again, goaltenders doing the splits, it is one possible mechanism, or anyone doing the splits, but it's not the most common mechanism. Osteitis pubis is sort of an umbrella term for undiagnosed hip groin pain. So osteitis pubis is often seen in sports, hockey for example, where there's a lot of wind-up cross, so it's in gymnastics where there's a lot of one-leg stance and a lot of shearing forces and rotational forces across the pelvis. So it's thought to be due to abnormal movement there, where you actually get change in the articular surface. So again, this is showing the excessive movement available at this level. But osteitis pubis is more of a diagnosis by default. When they can't come up with any other cause, it's often given the term incorrectly of osteitis pubis. please also be very aware that it's very, very common for the lumbar spine and the thoracolumbar junction to refer pain to the anterior hip. So again, looking at what causes in the lumbar spine could do that, anything then that affects those nerve roots can certainly cause pain there. But again, the pain is going to be related to back movements, not hip movements, but back. And as well, there will be changes in those nerve roots, whether it's dermatome or reflex or key muscle. It can also refer from the SI joint. Certainly SI joint more common in females, particularly young females who tend to have hypermobile or even unstable joints. One other common cause of anterior hip pain we have to be aware of stress fractures. So stress fractures, their hallmark symptom is night pain. They're often worse at night. They don't like vibration. So tapping distally from the site or ultrasounding, pulsed ultrasound over the site will create horrible pain for the patient. So what we're most concerned about, certainly stress fractures in this area can involve the femoral neck or the pubic rami. So these are often runners that develop these. What we're most concerned about are the tension stress fractures, because those are the ones that are more likely to displace and become complete fractures. So the compression fractures, the top diagram there, those are often treated non-weight bearing conservatively. But the tension fracture, where those weight bearing of any description, or even the weight of the leg, can actually cause that to fracture through. So those are usually surgically repaired. So the other causes of anterior hip pain, iliopsoas strain. So again, you see those in martial arts and gymnasts. Rectus abdominis tendinopathy. So again, hockey players are prone to those. Inguinal hernias can also give rise to anterior hip, and we talked earlier about those. Those are more common in males than the palpable mass. We also have to be concerned about infection. In this case, osteomyelitis, which is infection of the bone. So is there a history of root canal? Is there a history of inoculation? Is there a history of surgery? Lymphadenopathy is enlarged lymph nodes. So again, we're concerned, have these lymph nodes been enlarged for more than a month? Are they painful or non-painful? In the case of infection, they will be painful to touch, and again, they need to be treated. What I haven't got down here is infection. Probably the most common cause in young adults, again, is sexually transmitted diseases. What we're concerned about, though, are, from a serious pathology, is Hodgkin's, non-Hodgkin's lymphomas, which cause painless nodules lasting greater than a month. In children, one of the things that so the x-ray is actually showing a child. That's not a fracture across the neck, that's a growth plate. But what you see is a difference in the space there on the child's left side, and that's a synovitis. So that's actually swelling in the joint. So the synovitis is often no known cause. It might be traumatic, but it actually can prevent and create hip pain in the child, so a painful limp. But again, often it reduces on its own and goes away. It could be some very minor bump or bruise or whatever, or it could be insidious. Labral tears can also give rise to anterior hip pain. They often describe a clicking, deep and catching pain deep in the joint. So not to confuse that with iliopsoas tendon snapping over the pectineal line, but this is catching pain. It's a clicking or snapping deep inside the hip. Peripheral nerve entrapments. What's important about the obturator nerve is it mimics almost exactly an adductor tendinopathy. I know I learned in anatomy, we learned that the obturator nerve is a mixed nerve and it supplies sensation to the inside of the thigh. It's interesting, though, that when this nerve is entrapped, that it's often not producing numbness or tingling in this area, which is why it's often misdiagnosed as being an adductor strain or an adductor tendinopathy, because it is a nerve that passes through the adductor muscle. So the more the individual uses actively and resistance and overuse the muscle, the more the nerve gets compressed and the more symptomatic the patient is. So it is creating pressure on the motor branch, which creates pain. So again, it is the exception. So although it is an inert structure, the obturator nerve is inert, it in fact in this case is compressed by the adductor muscle overuse that compresses the nerve as it passes through the nerve passes through the muscle, and so it's the mechanical compression of the muscle that creates the nerve entrapment. The ilioinguinal ligament is one that can sometimes be caught up in scar tissue from abdominal surgery, and so again, or tight pants across the area. So those symptoms and peripheral nerve entrapments often have burning pain, they may have sensory loss, and they may have motor weakness depending on their function. Just to go back to peripheral nerve, the other one that's very common in this area is the lateral femoral cutaneous nerve of the thigh, and it supplies a patch of skin on the outside of the thigh, so it is a sensory nerve. It travels under the inguinal, or on top of the inguinal ligament, but right by the ASIS, and its claim to fame is on the rise because so many teenagers are wearing very, very tight-fitting, hip-hugging jeans that nerve is very susceptible to compression. And so the treatment is simply wear jeans that are the right size. Don't wear jeans that are so tight, you need 3 people to help you do them up. So the mechanical compression creates the numbness, tingling on the outside of the thigh. Rectus femoris muscle, so what is its function? So it does attach to the anterior inferior iliac spine, so it can avulse in adolescence. So what is its function? So it follows the theory of selective tissue tension testing, so normally you would not expect joint findings with it. You would expect pain on active and resisted function and passive stretch. So often it's a violent contraction, concentric contraction, or eccentric overload. So often the injury is associated with, for example, exploding out of the blocks in a race. So again, we can have avulsion fractures that can cause anterior hip and groin pain. So ASIS, we're thinking sartorius. AIIS, we're thinking rectus femoris. Can also cause this. So again, the pain is going to be localized to the bony area. The mechanism is going to mimic the muscle findings of the muscle that attaches to that bony area. As long as the bone stays in place, surgery is not needed. But if the bony fragment has displaced, they will tend to pin it. Slip capital femoral epiphysis can cause anterior hip pain, but remember 20% of adolescents who have it do not have symptoms. The things that we can't miss are the slip capital femoral epiphysis. So an adolescent obese presenting with anterior hip pain, we need to be looking at an x-ray because the x-ray is diagnostic. We need to also consider some of our abdominal pathologies, so appendicitis. So thinking of McBurney's point, halfway between umbilicus and the ASIS, when the patient is supine. Prostatitis, which is more in 50-year-old males, 50-plus-year-old males. Urinary tract infections, which are more common in females, and in this case particularly lower tract. Gynecological problems, and we've talked about those earlier. Inflammatory diseases such as Reiter's syndrome, ankylosing spondylitis, RA, all these things, they're systemic. They affect multiple systems. They have other joints affected, usually the hip and either ankylosing spondylitis. Usually ankylosing spondylitis starts in the SI joint or the lumbar spine, not so much the hip until after those joints are affected. So what other joints are affected? What other systems are affected other than the hip? Avascular necrosis. So again, if your patient has had a hip dislocation, they've had a fracture, they've had some sort of trauma, to the hip, even a labral tear. And now you're seeing them physio, they're not seeing the surgeon or the orthopod for 6 to 8 weeks, and they're reporting that their gait they're having more pain with gait. They were onto a cane, but now they're feeling they need to go back to crutches because the hip is so sore. That's when we need to be suspecting that that patient has avascular necrosis. Like Kath-Perthes disease, if this is the 6-year-old who's presenting with a painful hip, then we need to be looking at making that early diagnosis, because the sooner the diagnosis, the better the prognosis. So very, very important. The same with cancers, whether it's testicular or prostate or lymphoma. We owe it to our patients. These are non-neuromusculoskeletal problems, and the sooner we can send them back to their family physician for better investigations, the better the prognosis. Prostate cancer is the most common cancer in males, and it is very treatable the earlier it's diagnosed. The same with lymphoma. Certainly, we know that all cancers, the prognosis for a 5-year survival is incredibly higher the earlier it's recognized and treated. So what are our causes of lateral hip pain? Probably the most common is trochanteric bursitis, so a fall. So we have a deep and a superficial trochanteric bursa. The superficial is between the skin and the greater trochanter and glute med, and the deep is between glute med and the trochanter. So certainly a fall. It could also be due to rubbing across this area, so it could be IT band snapping across the greater trochanter and creating a bursitis. So again, the importance of this is often in falls, so that could be any age, but also in runners it's a very common problem. So not only could it be cardinal signs of inflammation, which would be heat and redness and swelling, but it could also be insidious onset. So with mileage and with running and with snapping because of the irritation created. The problems again with bursitis is they can become infected. So again, in which case the cardinal signs of inflammation would be present. So it's important to settle down the symptoms, but again, what is the cause? If it's a tight IT band, can we stretch it? If it's a problem with glute med, can we either stretch it or can we strengthen it? What is contributing to the cause of this patient's bursitis? Certainly, the physicians can inject it, and injections can be very effective as long as they are to the right place. So with this, a patient needs to be warned that they may well be more sore for 24 to 48 hours, but after that they should see significant improvement in their pain. Less common cause, so I talked about the lateral femoral cutaneous nerve. So it can cause pain at the anterior hip at the site of the entrapment, so you can see it's running on top of the inguinal ligament there, or it can cause pain or sensory loss or tingling, abnormal sensation over its area of innervation, which is the lateral thigh. So it can cause both anterior and lateral, probably more commonly lateral hip pain. So that's one, and that's our tight jeans and the cure or a blow to that area. So you see it in martial arts if somebody gets kicked and there's bruising or hematoma in that area, can temporarily entrap that nerve. The longer a nerve is entrapped, the worse the prognosis. So taking away the entrapment, taking away the hematoma with ice and trying to take away any kind of movement underneath it and allow it to be reabsorbed, or to take away the compression of a nerve is the best way. So take away the tight jeans. Snapping hip, again, can cause, so that would be related to IT band. So not to the point that it's irritating the underlying bursa, but the IT band can snap and create in and of itself. You can have an avulsion fracture of the greater trochanter by glute med, so a violent contraction of glute med or eccentric overload of glute med. Now we need to look at posterior hip and buttock pain. So certainly the common cause is pain that is referred to this area by sciatic nerve, so by the lumbar spine and by the SI joint. So very common. So if SI or lumbar spine movements or tests reproduce the patient's symptoms other than hip, then that would suggest they're the cause. So again, we need to consider that because they are very common causes of posterior hip and buttock pain. Piriformis syndrome. So piriformis syndrome normally passes anterior to the piriformis, but it does occasionally, as an anomaly, pass through piriformis. So piriformis is a muscle that tends to develop tone. It becomes hypertonic. And that can, when a muscle becomes tonic, so it's in tone, it can compress the sciatic nerve if that nerve is passing through the substance of the muscle. So it will look exactly like sciatic nerve reference because it is a sciatic nerve passing through it, but the difference will be is that the pain and the symptoms will only be distal to the buttock, meaning there will be no back pain associated with it because a nerve entrapment can only give symptoms distal to the area of entrapment. Since the entrapment is in the buttock, it can't cause back pain. So if your patient has pain that starts in the back and into the leg, piriformis can't be the cause. So piriformis has multiple functions. It attaches from the sacrum to the hip, and it has different functions in different positions. So it's a muscle that tends to compensate for a weak gluteus medius because it too is a lateral rotator of the hip. So it tends to take over the function if glute med is weak. And so for that reason, the treatment is to re-educate glute med to get it back doing the job so that we can turn off piriformis so it doesn't have to work so hard. And we're going to talk more about that in the labs. OA of the hip can also cause posterior, so it can cause anterior, can cause lateral, can cause posterior hip pain. Hamstring injuries are very, very common. I talked to you about the study of the Australian rules football players. So what we do know about hamstring injuries are that they tend to occur more commonly in individuals who have less neural mobility. So the sciatic nerve doesn't move as well. So certainly a hamstring injury can be grade 1 to 3. The tear tends to be mid-substance, and again, quite a significant injury follows the theory of selective tissue tension testing, meaning it's active and resisted functions will hurt, so hip extension, knee flexion, and passive stretch, hip flexion, knee extension, i.e. a straight leg raise, will stretch it. Normally, a hamstring injury will not have a joint problem, but remember that if the patient felt a pop and the pain is more over the ischial tuberosity, it's very possible that in their adolescent, it's very possible that they actually avulsed the ischial tuberosity and that it's not a mid-substance tear. A tendinopathy is going to look very, very much like a hamstring strain, the only difference being that tendinopathy tends to affect the musculotendinous junction. So, and it tends to be more microtrauma, so repetitive overuse, where a strain can be microtrauma, repetitive overuse, or it can also be macrotrauma, so an acute tear. But the treatment is very similar for both. With the avulsion of the ischial tuberosity, again, as I said, normally this bone will stay in place and it can be treated just the same as a hamstring injury, a serious hamstring injury. So they take a long time to heal, but as long as the bone heals, it will heal strong. If that piece of bone avulsion pulls into the muscle, then unfortunately they need to go in and pin. So if your patient felt a pop and you were concerned that it may have displaced, then an x-ray would be diagnostic. The ischiogluteal or ischial bursitis is one that we sit on, so that's a bursa that protects us, our ischial tuberosity, from hard surfaces. So certainly from that standpoint, it's also called Weaver's bottom. And again, like all bursitis in the body, acute bursitis do not follow the theory of selective tissue tension testing, but chronic do. This is an inert structure. It's aggravated by friction. It is a fluid-filled sac that's job is to prevent rub. So the the cause then is either a fall onto the buttocks to cause a traumatic event, or it can be chronic sitting. So individuals who spend a lot of time sitting can cause this, and certainly obesity is a factor as well. The heavier, the more friction created, and the more problematic. Last, we need to talk about our gluteal muscles. So it could be an acute strain, so glute max, glute med, so a lot of skate, rollerblade activities, so pushing off. So it could be a contusion to the muscle. So again, contusion can happen anywhere. Strain tends to be mid-substance, and both of these will affect the muscle's function. But the strain will follow the theory of selective tissue tension testing, in that it will be pain with hip extension, it will be pain with passive stretch, in the case of glute max. So contusion tends to be more superficial, and again,